I'm here with Susanna Duch. Susanna, you gave a wonderful talk today on narrow angle glaucoma. Before we discuss some of the things that you talked about, one of the important things that you talked about was staging, was grading. Can I get you to talk about that now?
Yeah. One of the most important things in angle closure glaucoma or angle closure is to unify criteria, because we need studies. There are some ongoing and a lot of already done in East Asia, and we have to speak in the same language, so in the same terminology. Now there are a staging, a grading for angle closure from suspicion to the certainty of the full disease, to the full glaucoma disease. And I think this is one of the most important messages that we tried to give yesterday.
Now, what are the criteria for each of these three stages?
Yeah, the first criteria for a suspect, so the until now called occludable angle, was and now it's going to be called angle closure, primary angle closure suspects, is just narrow angles. When you see by gonioscopy that trabecular meshwork is not seen in 270 degrees or more. This next step is when you already have angle closure, past or present, with, let's say, present because you know the symptoms, and past because you have some indirect signs, like synechias, intraocular pressure is high, you can have Glaucomflecken or even iris ischemia. And the third stage is primary angle closure glaucoma, when you can say that you have already glaucoma when glaucoma to optic neuropathy is present, is diagnosed. So you have three stages that are very clear, and some of the suspect will pass to the second stage, to angle closure, and some of the angle closure will remain chronic and will pass to the third stage, that could be glaucoma, angle closure glaucoma.
Now,
is that clear?
that was very clear. Let me, I'm tempted to ask you at what stage you treat and what the treatment is. But of course, one of the points that you make is that we can't approach treatment until we understand what the mechanism is in that particular patient. Let me ask you what the primary mechanisms are for angle closure.
Okay, not the primary, but most frequent and generally, usually more implied in some portion, in some amount, is the pupillary block. So that's why there is evidence that peripheral iridotomy should be the first treatment if treatment has to be initiated, so it has to be started.
And at what point would you, I understand this was not exactly the focus of the talk, but I want to ask you anyway, at what point do you initiate treatment if you are convinced that this is what the mechanism is for this patient? At what stage, what do you look for to determine that someone warrants a laser iridotomy?
Good. This is the best question. It's still a question for us too, because when to start with treatment with PI is quite controversial, because not all the suspects will develop angle closure.
Correct.
So perhaps we overtreat if we perform PI in all our suspects. But this is a matter of personal or individual opinion from any doctor, any ophthalmologist, and it will depend on racial too, on the risk in the racial glaucoma, because the anatomical factors are racial too. So let's say that we need to study a little bit more when to start PI, but right now in Caucasians, the Spanish therapeutical guides that were presented last year in spring recommends PI when the patient needs treatment that is risky treatment, or when the follow-up is not going to be easy So you're going to lose your patient, or the patient is not often coming to the office. So in these cases, PI should be perhaps mandatory or really recommended. In the other cases, it's up to the surgeon to think about the risks.
Yeah, I appreciate your humoring me with the digression. Let me bring you back to your talk. So you discussed mechanism number one. What's another mechanism that can be an etiology for narrow angles?
Okay, there are described four main mechanisms. You could say main trigger mechanisms. The second mechanism is in the plateau iris configuration, that you have different heights, and the height of the plateau gives you the risk. So not all plateau iris configurations should be treated to. And sometimes plateau iris needs a little component of pupillary block to trigger angle closure. So let's say that with iris plateau sometimes needs treatment, special treatment, because it does not respond to PI if it's pure plateau, or just follow-up, because it has been reported by Lee and colleagues that plateau iris configuration is quite anatomical variation, that almost 20 odd people, and with no difference between the ethnicities, I mean in Asian and Caucasians, can be present in normal patients, non-glaucomatous patients. So plateau iris configuration is an important trigger mechanism, but not always. We have to follow up. After plateau iris, we can count on a very important one. I mean, it's getting less important because fake emulsification is changing a little bit angle closure. That is the phacomorphic glaucoma. The phacomorphic glaucoma is described when anterior chamber depth is decreased due to the lens. The lens grows over the year, so increases its volume and gets, let's say, the curve, the anterior vault of the lens gets forward the anterior chamber and then closes the angle.
Sure. And then the fourth mechanism?
The fourth mechanism refers to any posterior force that pushes the lens forward.
Like aqueous misdirection
or Menick-Glenn glaucoma. Yeah. I mean, and I think this disease has a lot of names.
Yeah. Now,
we don't know really how to name it.
Now, you made the point very nicely that we need to understand the mechanism in an individual patient to determine therapy, but you also made the point that demographically, that racially, that there are substantial differences, particularly with the Asian population, in which angle closure is significantly more common, and you question whether we can directly translate the studies on Asian patients to Caucasian eyes, where the anatomy may be a little bit different.
Yeah, we cannot implement all this information completely, but it's what we have until we have more information.
Right.
And even in Asian people, there are differences between Indians, Inuits, Burmese, Chinese, Japanese. Yeah. So there are quite a lot of differences between the anatomy in different races.
Yeah, it's a wonderful point. A wonderful point. This is a great talk. I'm really glad, Susanna, that you brought all of this to us, that you've shared it with us today. Muchas gracias.
After this. Thank you very much.